bad.
What's up? Another episode of the Ripple Effect Podcast. I'm your host, Ricardo Brandes, also known as Ricky Brandes. Today we have an amazing information-packed conversation with Dr. Peter Mccullough. He had a bunch of videos that went viral. He's been on Fox and he was on Tucker Carlson. He was on Del Big Trees, The High Wire a couple times. He's been all over the place doing interviews, spreading his knowledge, wisdom, and information. And today is no different. He really packs a lot of information in this 1 hour conversation. Buckle in and get ready to probably get some information overload at some point during this podcast. With that said, remember this is a value for value podcast. If you get some value, please give some value back if possible. And that doesn't necessarily mean financial. Obviously, if you can't financially support the show, no big deal. Rate the show, review the show, share the show with your friends and family. Tweet it, post on your Facebook, text it to people. That goes a long way. I think these conversations and this information is super important. So if you guys can help spread them, thank you. And if you can financially support the show, first, if you can and you haven't, I'll keep saying it, stop being a cheap ass and support the show financially. But there's a couple ways of doing it. You can support the show on Patreon. You can support the show by using my PayPal account, and all this stuff will be in the show description. You can go to my website and find all these things also. rickyvarandas.com or the rippleeffectpodcast.com will take you to my website, and I'll have all the ways of supporting the show. I also have a merch store, which is the Ripple Effect Podcast merch.com, or you can just go to the rippleeffectpodcast.com and find the link to the store, and you can support me that way. So there's a lot of different ways of supporting the show. You can also support me by donating crypto. Just go to my website and you'll see the link to do that. Lastly, don't forget to check out my other show, The Union of the Unwanted, which I host with Sam Tripoli, Midnight Mike, and Charlie Robinson. It's one of the most important shows out there. Anywhere you can find the Ripple Effect Podcast audio, you can also find The Union of the Unwanted audio. The video will only be available on Rockfin and Odyssey. Or you can always go to my website and find all my shows uncensored at rickyvarandas.com or the rippleeffectpodcast.com. One last thing that's super important. Right after I recorded this conversation with Dr. Peter Mccullough, I rushed to the Ludlow High School for a Ludlow School Committee meeting. I found out about it last second, and what they're doing, they're going to vote if masks were going to be mandatory for kids in school or optional. A lot of local towns right before our school committee meeting were making it optional, so I was kind of optimistic. And then I went to the meeting and I saw the members and I heard what they said, and I lost a lot of faith. So since then, if you follow me on social media, you might know that I created a petition, and I've been trying to put pressure on the Ludlow School Committee to make masks optional for children. Let the parents decide. Give us the freedom to decide what's best for our children. And the petition will be in the show description. And then also, I did an emergency episode. Maybe some of you guys have listened to it. Maybe some of you guys haven't. It was episode 345 that discussed what was going on locally and why we were so upset about it. So if you want to hear more about that story, please check out episode 345. Also, go in the show description. I'll put links to the petition, and I'll put links to that episode in the show description. And we have another school committee meeting coming up on August 24th. So I'm hoping that with your guys' help, we can put a little pressure on the school committee and force them to make the right decision. Everybody who's been supporting me with all this, I truly appreciate everybody who signed the petition, everybody who shared the petition from the bottom of my heart. I truly appreciate it. You're helping me, and more importantly, you're helping my children. And if you follow me on social media, you see my kids. Those are the faces. You're helping. Thank you. Enjoy the show, and I'll see you guys in the next one. Peace.
I believe in the ripple effect. doesn't have to be that much in the way of opinions. We just give the data. People just want to know. They're hunting our medical licenses for, quote, misinformation. So you're going to hear me quote a lot of first authors' names and quote the citation, and it's going to be pinpoint. And when I go on national TV, it's the same way. It's just laser pinpoint, because I expect to be challenged. Oh, you're giving out misinformation. And I'm going to say, listen, let's just go over it. I was on earlier today. I said, listen, let the fact checkers, let's fact check this paper because it shows this, and, just challenge it. The fact checkers are just afraid to even touch me because they're afraid to publish or publicize the facts.
Yeah, you're right. So they avoid debates with anybody who is actually informed and
oh yeah, there's nobody's touched me. There's nobody's challenged a single point I've made.
Well, let's get right into it. For people who are listening, and we'll jump right into the conversation. For people who are listening who maybe aren't familiar with some of your background, before we get into some of the current events and some of the stuff that's going on now, can we get a little bit of an origin story for Dr. Mccullough?
Sure. I'm Dr. Peter Mccullough. I'm an internist and cardiologist. I maintain my board certifications in both specialties, and I practice in Dallas, Texas. I see patients every week. I'm also an academic physician. I'm the editor-in-chief of two major medical journals, Reviews in Cardiovascular Medicine and Cardiorenal Medicine. I'm the current president of the Cardiorenal Society of America. And so I really stepped up in response to the COVID-19 pandemic. And I think what I've done is really work to fill a void. There was a giant void starting in March where patients were not being treated for COVID-19 at home to prevent hospitalization and death. And none of our government leaders, none of the task forces, none of the agencies, none of the academic medical centers ever made it a priority to treat sick patients at home, particularly the high-risk patients, and avoid hospitalization and death. So I've been very involved in this. I have over 45 peer-reviewed publications. I've had U.S. Senate and state Senate testimonies. I've been an expert and opined in many different venues, really all over the world. I've been a national expert on TV and for the U.S. public, as well as TV in Europe and Australia and elsewhere. I'm trained as a medical doctor, but I'm also trained in epidemiology. I have a degree in epidemiology, which is the right specialty to study an outbreak like this from the University of Michigan. And I've had the illness myself. I know what it feels like. The illness has affected multiple of my family members. So I can tell you, as we sit here today, I think I have the greatest amount of authority to give my analysis of what's going on than anybody in the world.
With that said, when this all started happening, what were your thoughts on what was going on? Were you initially skeptical on the way they were reacting? Were there some red flags that immediately got your attention?
I think one of the most interesting observations is we started hearing about this, I think, when there were 10 cases in China. And it's like, well, what type of viral illness is worldwide noteworthy in 10 cases in China? And I honestly wasn't really tracking along with a lot of the development work on pandemic response. I really wasn't. I was focused in my area. And I remember I had actually misjudged the pandemic in terms of its overall impact. And I was telling some of my colleagues, I said, either this is going to be the most overblown thing ever, or this is going to end up being like Armageddon. And in a sense, it's end up like Armageddon.
But when you say that, do you think it's because of the virus or the way we reacted to the virus?
I got to tell you, I think it's both. So let's take the virus. The virus is a coronavirus. It's in a family of viruses that cause the common cold. But we had already seen one version of this called SARS-1. And SARS-1 was, for most places that was hit by, it was about a 90-day experience of a contagious virus that didn't have much in the way of treatments, and it did have some fatalities associated with it. But people got through it pretty quickly. I remember communicating with a friend of mine in Canada. They got hit with SARS, and he says, listen, he goes, I had to wear a mask at work for about 90 days, and I got through it. So I was actually thinking that that's what we were going to be. And I remember President Trump when he said, oh, it's going to be just get to Easter and we're going to get past Easter and this is going to be done. And then we realized this virus was much different. This virus was basically the SARS-1 virus, but there was a modification in the spike protein, the spine on the ball of the virus that made it far more contagious and far more deadly. And what we found with this virus is that it had a very long phase of the virus just replicating within the human body for 2 weeks. Like, what virus just churns for 2 weeks in the human body? But this one does. It triggers off inflammation in the human body, which is unlike anything we have seen. It has an interesting pattern. One of the lead inflammatory factors is called interleukin-6. We've never seen an infection where interleukin-6 is the lead. This infection, instead of raising certain components of the white blood cell count, it actually depresses them, particularly the lymphocyte count. The only other illness that acutely depresses the lymphocyte count is the HIV virus acutely. So that was interesting. But the big difference with this virus and all other viruses, very, very important for listeners to understand, is blood clotting. Blood clotting, the spike protein, that spine on the ball of the virus, is tremendously thrombogenic. It attaches to red blood cells. It causes the red blood cells to start to stick to one another. It markedly activates platelets. The platelets then release factors that cause more platelets to pile on. And the blood clotting that occurs in the body is nothing like we've ever seen with the virus before. The Italians broke the news with the first courageous autopsies that showed micro blood clots in the lungs. And then the Japanese and other reported, large strokes, big blood clots in the legs and elsewhere. Heart attacks. We published a paper from our center showing that if someone has a heart attack and they have COVID-19, we put in a stent. Normally, there's way less than a 1% chance of that coronary stent occluding. In COVID-19, our reported results was 20% of these stents would clog. So we found that this was a super blood clotting problem. And to this day, that's under-recognized. People want to be grabbing remdesivir or grabbing hydroxychloroquine or ivermectin. And I just finished advising a family in the hospital. The guy's 12 days into it. He's on a ventilator. The oxygen level's low. He needs blood thinners. It's micro blood clots in the lungs. We need high-dose aspirin and we need blood thinners. And the analyses of these, as published in the peer-reviewed literature, observational data in patients, all show that full-dose aspirin and full-dose blood thinners are associated with reductions in mortality.
Yeah, one thing I noticed when this all happened or started happening, I was kind of on the same boat that you were. I didn't know if this was going to be way worse than I was assuming, or it was going to be nothing. And I'm like, and the media has a big part in that, because I know people like Dr. Drew and other people were going around saying like, hey, the media is the one scaring people. Like, this is just going to be a bad flu. We're going to get through this. And when the media initially reported on the first deaths in the US, I think there was the first 40 or something like that in the US. One thing that I thought was really weird was they didn't once mention it was all in one state in one nursing home. They just kept giving you the scary number. Oh, it's now infiltrated the US. We should be concerned. We should be afraid. And then as time went by, and I've always been very skeptical of the media, so, this isn't a surprise to me, but I could see the script, and they kept giving us more numbers that were scary, like case numbers, which was using a PCR test, with using high cycles, which were causing a lot of false positives. And these case numbers, there were large numbers. They were scary. They weren't telling you the numbers that might be reassuring, like how many people are recovering, how many people are getting better, all these things. Did that also get your attention, that it seemed like the media was also, because you work at a hospital, and we kept getting media reports about how bad hospitals were and how overwhelmed they were. What the media was saying, was it a real reflection of what you were seeing in your line of work?
Well, in March 2020, we got the word that oh my gosh, we were going to be clobbered with this virus. We shut down the operating rooms. We shut down the heart catheterization laboratories. We started putting people on these different shift cycles. A lot of us, we're older. I'm over age 50. We thought maybe we could be at risk. We got out of the hospital. We started WebExing, and we were waiting for Armageddon in March and April, and it really didn't happen. And we kind of went back into the office. We didn't see many cars in the parking lot. We knew that the hospital census was down. Where were the patients? The patients weren't there in the spring, quite honestly. We were so prepared. And so I started getting a sense that, boy, something is really out of sorts here. And I agree with you that we Americans saw things that we never saw before. We saw a scoreboard that came up on CNN and Fox and MSNBC. There was a scoreboard on the TV that almost real time gave the number of deaths and hospitalizations. And I wondered about this. I said, how is that scoreboard created? How did that? And it said Johns Hopkins Bloomberg School of Public Health. How did they do that? How did that become an instantaneous scoreboard? I can tell you, as a doctor, when a patient of mine dies, sometimes the death certificate doesn't come to me for like 4 weeks. And then I sit down and I'll figure out what I thought the leading cause was death. How are these deaths instantaneously getting up in the scoreboard? I'm not an expert in this. I still can't answer it, but I can tell you one thing that gave me a lot of insight is that in 2017, Johns Hopkins School of Public Health had a symposium, and the name of the symposium was called the SPARS pandemic. The SPARS pandemic, and they produced an 87-page proceedings of this epidemic. And then quickly in March of 2020, they got their paper actually into the peer-reviewed literature where you can actually review the proceedings of the 2017 meeting. But in that meeting, they said, we're going to get hit with a virus. It's going to be a coronavirus. It's going to be related to MERS and SARS. They thought it was going to hit 2025, but it's obvious it hit in 2019 or 2020. They said there's going to be a drug. They had a different name for it, but it turned out that was hydroxychloroquine, that there's going to be great confusion regarding this. And then the media and social media and everything is going to converge on the plan for mass vaccination as the principal way of handling the pandemic.
And do you think that is the way to handle a pandemic, mass vaccination?
Well, no, and I think America knows that. I mean, I led the very first team of US doctors and Italian doctors, and we published the first outpatient treatment protocol of how to treat COVID-19. And we didn't wait for large randomized trials. We used the precautionary principle, which basically said, listen, we're going to use our judgment, drugs that make sense, thinking that no single drug can treat a virus that's so multidimensional because there's viral replication, cytokine storm, and thrombosis. We know a single drug is not going to work. We were never going to expect a single drug to work. It's very important for your audience to hear this because everyone wants to grab a drug and say, aha, this is the miracle. And we've seen America go after this over and over again. Hydroxychloroquine is a miracle. Oh, remdesivir is a miracle. Oh, ivermectin is a miracle. And we keep going through this. No, Americans, no, we don't even treat a staph infection with a single drug. Doctors always use drugs in combination. And I knew that as a doctor, that I had a very good feel for the data. I worked with experts all over the world. We were talking to the doctors in Milan. What are you guys seeing? And we published our breakthrough paper, American Journal of Medicine of 2020. It immediately became the most downloaded and utilized paper for outpatient treatment of COVID-19. Published the updated version in Reviews in Cardiovascular Medicine of 2020 and December of 2020. And that really set the template, which is still used today for the most frequently used outpatient treatment guide. And we're able to kick off treatment with FDA, EUA approved monoclonal antibodies, the Regeneron antibodies, and then sequence our drugs in. We now have with hydroxychloroquine, we have 300 supported studies. With ivermectin, we have about 60 supportive studies. We use steroids, both inhaled steroids, inhaled budesonide, 2 supportive randomized trials. Oral steroids, we have a meta-analysis of a dozen trials of oral steroids. We use colchicine, supported by the largest randomized trial that exists, the Corona trial, strongly positive with colchicine. And then we put everybody on high-dose aspirin, 325 milligrams a day, and high-risk seniors, we go ahead and put them on Lovenox injections or oral apixaban. So what I've just described for your audience is what's called sequenced multidrug therapy to reduce the risk of hospitalization and death. 2 good papers, one by Proctor, done here in the DFW, the legendary Dr. Zelenko, Monroe, New York, show that when we use drugs in combination, we reduce the risks of hospitalization and death by 85%. I can tell you personally, I've advised on cases where we range up to people in their 90s and treat them at home, treat them in the nursing home, and the drug regimens can actually vary. They can actually have a little bit of different, they can be tailored to the individual. As long as patients are getting about 4 to 6 drugs, we can get them through the illness and markedly reduce the chances of hospitalization and death. And I've treated patients with heart failure, emphysema. Now, I have had some patients be hospitalized. And in fact, I saw a patient in follow-up recently where last year we ran the sequence of drugs, including the monoclonal antibodies. He did get sick enough. He went in the hospital. He needed a few days of oxygen support and IV, and he went home. But he wasn't committed to a ventilator. He didn't have this awful outcome where he died in isolation. We avoided the horrors of COVID-19. And as we sit here today, the only people being admitted to the hospital and being put on ventilators are largely people who get no outpatient treatment for COVID-19. It makes sense. If we had an outbreak of staph infections, the only one that would get staph sepsis and have to go in the ICU would be those who got no antibiotics at home. It's the same principles. The same principles apply. Americans should know infections need early treatment at home.
Yeah, I had Dr. Joel Hirschhorn on, and he wrote the book Pandemic Blunder. He talked about Dr. Zelenko and many others. And a lot of what he discussed was how there were these alternative, I shouldn't say alternative treatments. There were these, maybe the vaccine's alternative treatment. There were these treatments that people were having success with, and they were being ignored. And in many cases, conversations about them became suppressed. And when people who study medicine, who are doctors, have PhDs, are experts, and they're being suppressed and they're being censored from discussing their opinion. And like I've said on the show numerous of times, I mean, it's not uncommon for doctors to disagree with one another. I mean, that's why we say get a second opinion, get a third opinion. You might look at the information and maybe just come out with a different outcome, a different perspective on it. So all of a sudden, the media and big tech decided, well, we're going to be the ones who decide what truth is, and our opinions are the only ones that matter, and we're going to suppress everybody who disagrees with us. And when you start seeing the suppression of these possible treatments, and I mean, even New York, regardless of politics, I thought it was completely outrageous that they purposely made, I think they made it basically illegal and impossible for a doctor to write a prescription for hydroxychloroquine. And Cuomo should have, to me, it's outrageous to think that any politician should get in between a patient and a doctor, and that should be between them, and they should decide what is safe or unsafe or whatever. So it was just another example of how a lot of this was political or had other motivations, and it didn't really seem like it was about protecting people, because if it was about protecting people and getting people treatment, then why were all these other things like hydroxychloroquine, ivermectin? I mean, when Dr. Robert Malone was on my show, he said that he thinks his interview that he did with Brett Weinstein on a Dark Horse podcast, he thinks it was the mention of ivermectin that got him in trouble. I mean, why are people who have PhDs who understand this information, why can't, to me, it's outrageous that they came and have these discussions. So I guess my point of this long rant, sorry, this topic gets me a little passionate, just like I'm sure it gets you. But my point is, why do you think that was? Why do you think that all these treatments where there were people having success with them, why weren't these things force-fed to the public? Why weren't we talking about this publicly?
Something happened very early in March or April where it came into the minds of people that COVID-19 was going to not be treated, and that there was going to be efforts done at every level to deny treatment. And it's the most interesting thing. When I interviewed with Tucker Carlson, I pointed out that in Australia, in Queensland, Australia, they put on the books a law that said if any doctor tries to help a patient with hydroxychloroquine, that's punishable with up to imprisonment. Now, hydroxychloroquine is over the counter in a lot of countries. I use it every day in my practice for rheumatoid arthritis, lupus. I'm in my 4th decade of practice, fully board certified internal medicine, cardiology. I know this drug inside and out. I know the risk benefit relationships. It's not a scary drug to use. It's on the order of using Seldane or or another drug of that nature. Is very, very it's safe to use in pregnancy. There's very few drugs we can actually give to a fully pregnant woman. We were doing that for years. It's given to missionaries. People go over to Africa for malaria prophylaxis. It's a very diverse and high quality medicine. Why did they put on the books so early in April? How did they know that hydroxychloroquine was going to be so important that they were going to put a doctor in jail for it? And then immediately things started happening where Didier Riault and Matthew Milan in Marseille started doing some research with it. And they said, listen, it looks pretty good. There were papers early on by the National Institutes of Health in 2006. It looked like it was really good for SARS-1. It looked so good that countries, including the United States, stockpiled hydroxychloroquine. So it's ready to go. So now it's stockpiled, and now then it's blocked. And the blocking in the United States of hydroxychloroquine was very interesting. So there was an emergency use authorization put on hydroxychloroquine for inpatient use, something that was not needed. We don't use emergency use authorization for existing generic drugs. The EUA is actually for new drugs to get on the market. And it was subsequently used for the monoclonal antibodies and the vaccines, but it wasn't needed for hydroxychloroquine. So almost in a sense, that became a restriction that we should not use it as an outpatient, where that's where it really works well, but we should use it as an inpatient. And then on the inpatient side of things, what happened is there was a falsified paper published in Lancet, one of our major medical journals, a fake paper from a fake database. And I'm the editor of two major journals. When finally this paper was shown to me, I knew it was a fake in 2 minutes because it was from very early on the pandemic. It had tens of thousands of hospitalized patients with detailed drug information, which we never have. And the average age of people hospitalized was in their 40s. We don't hospitalize people in their 40s. At that time, it was people in their 70s and 80s who were being hospitalized. So I said, wait a minute, this is a fake paper. And sure enough, Lancet let it hang up there for 2 weeks. Fake papers, by the way, are never published. When I mean falsified, I mean flat out falsified papers. That would never happen. I'm the editor of a journal. We've got review staff. We've got associate editors. We have all these checks. We check things. The peer review process is airtight. It would never happen under my watch. This paper, in fact, today I did editorial work for my journal and I rejected some papers. I mean, I am airtight in this. Suddenly Lancet, one of the best resourced papers in journals in the world, had a complete lapse, and they publish a fake paper that says hydroxychloroquine, in fact, could harm patients. And they let it sit on the website for 2 weeks. And then without really any apologies, they took it down. And so that scared the world. In fact, that triggered the US FDA to say, listen, don't use hydroxychloroquine at all. Say, wait a minute, we never even got going with using hydroxychloroquine as an outpatient. It turns out hydroxychloroquine is not essential, but it's very useful. And so all the small randomized trials of outpatients that's been summarized in an analysis by Ladapo and colleagues show about a 25% reduction in events. And then on the inpatient side, we have 5 small randomized trials, none of them big enough to discern anything. There are only 2 placebo-controlled randomized trials as an inpatient, one of them done by the US National Institutes of Health. These are tiny trials. We've had millions of people hospitalized. We've tried it in a few hundred patients, and it showed hydroxychloroquine, when given very late, was neutral. None of them were big enough to find a benefit if indeed it exists. But we did have large prospective, well-done comparative studies, one by Henry Ford Hospital, 3,000 inpatients, and when started early, there was a mortality benefit. We have one from Iran as an outpatient by Mokhtari, nearly 30,000 patients, large reduction in mortality in the 25% of high-risk seniors that they choose to use hydroxychloroquine. So to this day, hydroxychloroquine is bread and butter for outpatient management of COVID-19. There are treatment networks. In the United States, we have Association of American Physicians and Surgeons. We have the Frontline Critical Care Consortium, American Frontline Doctors. We have BIRD in the United Kingdom. We have Treatment Domiciliary, which is a very heavy hydroxychloroquine utilizing group. They've declared 0 hospitalizations in most cities in Europe with hydroxychloroquine-based multi-drug protocols. We have PANDA in South Africa, COVID Medical Network in Australia. So in a sense, these hero doctors stepped forward and they worked with drugs. In fact, hydroxychloroquine and ivermectin are the lead drugs done early. But Dr. Barentios in South America, Dr. Shetty in South Africa said, listen, these are so controversial. They're putting doctors in jail for this. Forget it. They treat the back end of the syndrome with antihistamines, anti-inflammatories, steroids, and anticoagulants, and they still save patients. So the bottom line is you can treat this syndrome with so many different options. Dr. Paul Alexander published a wonderful nursing home study of all these nursing homes that tried different things. As long as you did something, some drugs in combination, the reduction in mortality could be 60%. As we sit here today, the only bad data that we see, even in the Delta pandemic, is untreated patients. All these hospitalizations, untreated. Patients are scrambling to get some care and nobody's offering it, so they end up being hospitalized. And unfortunately, for many patients, it's too late. That's who's dying. It's a crisis of the untreated.
And is that because there's no guidelines or no unity in how to exactly treat this? Like, basically, we've been telling people, get vaccinated, that's your only hope.
The authorities now, the National Institutes of Health and the Infectious Disease Society of America, the two bodies that create guidelines, they have not comprehensively addressed outpatients. In fact, they basically say, wait for patients to get sick enough and then wait till they go in the hospital, and they have to be sick enough to need oxygen, and then start treatment. And they're so far behind with treatment. Their lead treatment is remdesivir. Well, I can tell you the virus is long gone by the time they're trying to treat with remdesivir. In fact, when the oxygen level's low, that's blood clotting. They actually need blood thinners. So even the inpatient guidelines are so nihilistic and so off target. The inpatient care is atrocious, and families are frustrated with this. Do you know families have gone to court and said, listen, treat my mother and father appropriately with multiple drugs? They have to go to court, and there's attorneys that actually have to get court orders to force the doctors and the hospitals to treat the patients correctly. It's been done over and over again. So it's in the minds of people, not just the authorities, but all the way down, to not treat patients with COVID-19. So if you were a patient of mine and you got sick and I decided to prescribe you hydroxychloroquine or ivermectin or another drug, you would face barrier after barrier after barrier. Here's a little one. So it's legal for me to prescribe you hydroxychloroquine. I would prescribe it for you. You'd show up to the pharmacy, and then they would ask you, is this for COVID? And if you said yes, they would say, well, I have to call the doctor and double check the dose. They don't have to do that. Now, every pharmacist in the country is thinking about this. And then when they can't get the doctor on the phone, which is common because we're seeing other patients, they'll say, you know what, I can't give you this medicine. And so they happily deny patients medicine. To this day, we estimate that's done at 15% of pharmacies. And I've had pharmacists call me up. Well, do you know that the National Institutes of Health guidelines say you should not use ivermectin to treat COVID-19? I said, listen, the guidelines say there's not enough evidence for, there's not enough evidence against. But if you look on page 8 in the guidelines, it says ultimately it's the doctor's decision. So it's in the minds of people to deny treatment. And I've done some programs on Clubhouse on the phone, and this is happening in the smallest little island in East Asia. It's occurring in the forests of Africa and South America. There's people who, they don't even know who the World Health Organization is. They don't even know what a vaccine is. It's just in their minds that they're denying people treatment. And these activities keep going. You know, the second largest hydroxychloroquine plant outside of Taipei was mysteriously burned to the ground. Do you know these stockpiles of hydroxychloroquine in many countries still have not been released? I was on a call today with an official in Ohio. The stockpile in Ohio of hydroxychloroquine still hasn't been released. Do you know that there's barrier after barrier? Let's just take monoclonal antibodies. That should not be controversial. That's FDA, EUA approved. Do you know when I testified in the Texas Senate, right ahead of me, there was a nice doctor. She told about her father's in his 90s. He got monoclonal antibodies and was saved. So I got up there and I really, I've been waiting all day to give my 2 cents. I really fried the committee. I said, where are these monoclonal antibodies in Texas? Where's the 1-800 number? How does the next senior on their scramble for treatment, how do they find these monoclonal antibodies? Everybody looked at me like, we don't know. And within 2 days, there was legislation written by Senator Bob Hall that says, listen, let's get an information sheet. When people get COVID-19, let's get an information sheet about where these monoclonal antibodies, what other drugs and vitamins and supplements play a role in the treatment of COVID-19. And let's get some basic information to patients. For instance, Association of American Physicians and Surgeons has a patient guide. It's been a fully vetted guide. It's the most frequently used patient guide in all of COVID-19. It's been available since October of last year. Do you know that legislation got going? And about 2 weeks later, the Texas Medical Association of Doctors, struck down that legislation and said, we want to replace it with a vaccine registry. So there is a theme that's been going on from the very beginning to squash any hope of treatment to patients, any relief from this syndrome, anything that can keep them out of the hospital. And it's designed to promote as much fear, suffering, hospitalization, and death. On the flip side of this, I think, to drive mass vaccination. And it's been going on, I think, from April forward, and it became overt in December. In December, it was just announced that what the plan was. Remember, I told you the Johns Hopkins document said that was the plan in 2017. Well, in early December, the BBC announced with major media and major social media the Trusted News Initiative. And everybody should know about this. The Trusted News Initiative said, we are going to squash anything on early treatment, anything on vaccine safety in order to promote the vaccine, to basically eliminate vaccine hesitancy. And since that time in early December, that's all we had. You're right. Mention ivermectin, you're scrubbed. Mention any hope of treatment, scrubbed. Mention anything on vaccine safety, forget it. And you know that with vaccine safety, our CDC and FDA, they owed it to Americans to have weekly press briefing on safety, at least monthly press briefing. They owed it to America to have a critical event committee, a data safety monitoring board, a human ethics committee. They owed that to America. They would have done it in any other research program. But now with this new program of just promoting the vaccine in an unbridled fashion, there's no information given to Americans on safety. And you can tell that other agencies aren't comfortable with that. So they're trying to speak to America. So for instance, the FDA is telling Americans, listen, this isn't safe. We've got heart inflammation that occurs in young people with Pfizer and Moderna. It doesn't look good. They have a warning out on this. We know that we're coming up on 4,000 cases of young people who don't need the vaccine having this heart inflammation that doesn't look good. We have the FDA telling us on J&J, listen, we've got blood clots forming in women age 18 to 48. That's a big group of people up in the brain and elsewhere. This doesn't look good. We have a warning from Johnson & Johnson about paralysis called Guillain-Barré syndrome going up the body. Canada, they got a warning, AstraZeneca doesn't look good. Facial paralysis on one side. And all of these events that come out, they're not rare. We should be conservative and say that, you know what, we see these sporadic cases, but they could be the tip of the iceberg. That's the correct way to handle data. I've been a chair of data safety monitoring boards of some of the biggest programs around. I know what I'm talking about. We never play down safety. In fact, we're conservative and we play up the issues of safety. And Americans know that because when they watch a TV commercial for an FDA approved drug, it always says, warning, may cause this, you always get the disclaimers. Americans know when they get a drug from the drugstore, there's a big list of safety precautions. That's to protect Americans. Right now, Americans are getting zero safety information from the authorities on vaccines, none. And they're given no guidance on what to do. Doctors were given no guidance on how to manage these vaccine injuries. The CDC has already told America we have over 500,000 vaccine injuries, 500,000. There's no guidance on how we should manage them. How do I manage a blood clot? What do I do with the next kid with heart inflammation? What are my best approaches? How long do I have to worry about this? What information do I tell the parents? How about the blood clots that are forming? So you can imagine what a mess this vaccine program really is. It's beyond the wildest imaginations as probably the biggest catastrophe of a biological product ever used in modern medicine.
Well, I think the demonization of a lot of treatments was because, correct me if I'm wrong, it's because to fast track the vaccine, they basically needed to show the world that there is no treatments. This is our last resort. This is how we get to fast track a vaccine because we have no other option and this is our last resort. So that was, I think, a big motivation. You talked about the Lancet study. That was super frustrating because everybody talked about it when it was posted, and then once it was pulled, nobody brought it up. Nobody talked about how it was exposed to be fake and it was bad science, and they pulled it and all that stuff. So it to me that's very frustrating. In regards to the vaccine adverse reactions, I know Del Bigtree says this all the time, and it's so true. There was that one study, I believe it was Harvard, who who studied the VAR system, and they said 1% are inputted into the system. So who knows what those numbers are? When you look at risk to benefit, I mean, this, and another thing you talked about, just when something gets FDA approved, when a drug gets FDA approved, there's many examples of a drug that goes through the whole process, gets FDA approved, and then gets pulled because of adverse reactions or deaths. Now, this thing is fast tracked, and all of a sudden we believe that it's safe. And what evidence is there that it is safe? I mean, what type of safety studies did they actually present to the world to show us and give us some type of confidence that this is a safe thing?
Well, safety has to be proven. I like the way you set that up. Because safety has to be proven. It shouldn't be assumed. And so it should be safety, safety, safety. That's the reason why we deserved weekly safety briefings on the vaccine, or at least monthly safety briefing. I mean, we were going to have these government vaccine centers, not staffed by doctors. A doctor's order is not needed for this. Somebody could just walk off the street and walk into one of these vaccine centers, and there were no provisions for safety, none. So that patient could walk into the vaccine center, have the vaccine, and just die in the vaccine center. In fact, that happened. People filmed that on their telephones. It was absolutely horrifying what happened. And where we were was, for a program this large, in the whole United States, we give probably about 275 million shots a year across 70 vaccines. The number of deaths that get reported into the data system, not related to the shot, but they do come in from various sources, is about 150 deaths a year for everything. And that's for a much larger number of shots than the COVID shots so far. But I can tell you, at 27 million COVID shots on January 22nd, we were at 186 deaths. We were well above the expected. So at 27 million Americans vaccinated, and remember, the vaccine rollout was young healthcare workers and nursing home workers. They hadn't even gotten to the seniors yet. Those were deaths among young people. That was January 22nd. If we would have had the proper external committees looking over it, and we needed doctors working in teams. Again, this is my business, this is what I do. They didn't ask me or anybody else. They asked nobody to look at these deaths. At that number, we should have had a day safety monitoring board shut down the program in February. Say, listen, shut it down. Even though it looked good out of the clinical trials, we're above a safety signal here. Don't forget, we had already crushed our curve with early treatment early in January. So there was no emergency. The early treatment networks were established. People were being treated. There was no emergency late in January, none. And there was no mention of it. I kept waiting for a press briefing. It never happened. When is the CDC and FDA going to comprehensively review safety? And it kept going and going and going. And people started getting more and more uncomfortable. So one of the tools we rely on is called OpenVAERS, and it's an overlay. It's a computer overlay that sits over the vaccine event reporting system and gives us a weekly update. OpenVAERS is valid. We are at today 12,000 deaths, 12,000, not 185, 12,000 deaths. We're at over 200,000 hospital admissions, ER visits, and office visits after the vaccine. They're kind of urgent visits. People are getting acutely sick. In total, we have over 500,000 injuries. These are with permanent VAERS numbers. They get reported at first, takes multiple pages. Doctors or nurses fill these out. They think the vaccine is the problem. They fill out these forms dutifully, and then the CDC holds them. They have a temporary VAERS number, and then the CDC verifies it. And I filled out some of these forms, and the CDC calls me, and we go over it, and they verify it, pinpoint. Then they become permanent VAERS numbers. So the numbers I just gave your audience are the permanent numbers. That's what really happened. We don't know what the backlog is. We don't know how many more of these are going to happen. But there's another way we can look at deaths. We could go to the Center for Medicare and Medicaid Services. People who are on, about 18% of Americans are in Medicare and Medicaid, and they record the vaccine status. So actually we know that. And we know when they got the vaccine. And there, that data was used several weeks ago to file a lawsuit, a temporary restraining order to shut down the program. And by using CMS data and using the VAERS data, the projected estimate a few weeks ago was 45,000 deaths. 45,000 deaths. Temporary restraining order, shut it down. There has been no shutdown of the program. In fact, there's been a doubling down. Now the doubling down is, listen, take the vaccine or lose your job. Take the vaccine and you can't travel. Take the vaccine and you can't, manage your life anymore. And there's never been so much tension in America as you can imagine. People listening to this say, wait a minute, I could be the next person who dies with the vaccine, or I could be permanently injured. I could have a permanent neurologic injury, or a permanent damage to my heart, or a blood clot that damaged me. The FDA says it can happen. The FDA is giving us these warnings. Watch out. FDA is telling Americans it's not safe, but yet employers are telling people, listen, you have to take it. But the CDC says, no, it's optional. The CDC consent form says it's completely optional. We're in the weirdest time. Do you know the American College of Obstetrics and Gynecology says we strongly encourage the vaccine for pregnant women? And pregnant women were excluded from the randomized trials, no safety data. We always assume something is dangerous for a woman instead of being safe. We don't assume it's safe. We assume it's dangerous. So this would be automatically pregnancy category X. We assume it's dangerous because the vaccines have a dangerous mechanism of action in the human body. And so many people have died or been hospitalized. Why wouldn't we assume it's dangerous for pregnant women? The FDA did. FDA excluded them from the registrational trials by the sponsors. But the American College of Obstetrics and Gynecology says we strongly support it. So a pregnant woman would actually go to a vaccine center like mine, and they would look at the consent form. And the consent form says, special section, check, I'm pregnant and I know there's no information on safety. And I know that we haven't seen safety. They're almost trying to speak to pregnant women saying, watch out, don't do this. And so it's the most unusual time I've ever seen in medicine. And as you can imagine, of course, there have been lots of reports of miscarriages and stillbirths. Pregnant women should get nowhere near this vaccine. The vaccine these are all genetic gene transfer technologies, never been used before. They transfer genetic material in the human cells. The human cells produce this spike protein, this dangerous spike protein that circulates at high concentrations, circulates. These use it for 2 weeks. It may stay in the body for months. The genes that produce it may stay in the body for months. And this spike protein causes the body to attack its own cells. We know it hyperconcentrates in the ovaries. That's been shown. That it shouldn't make anybody feel comfortable about that. The spike protein itself and the genetic material go into the brain. Since when do we have a vaccine that goes into the brain, a vaccine that goes into the heart? And then it starts producing the spike protein. The body reacts to it. There's damaging to this organs, and then it circulates freely in the bloodstream, damages blood vessels, causes blood clotting. Since when would we ever have a vaccine like that get into broad use with no safety mechanisms? None.
Yeah, I've seen so many videos of parents who are pro-vaccine, who have basically were excited to let their kids get this vaccine, and then they're injured and they're trying to share their stories. And then I'm trying to share these videos with people and you can't find them. And I'm like, we live in such a crazy world where people who are, these stories, there's risks to everything. People should know all sides of the story, get all the information, then decide for themselves. You filter out or you fight bad ideas with good ideas, like I always say, and you give people all the information and assume that we're intelligent enough to decide what risks we want to take and which ones we don't want to take. The thing about the vaccine, I've been saying this a lot to friends and family and people that I know. I'm like, the thing about COVID, one thing we pretty much understand pretty well is that it's mostly older people and mostly people who have already a lot of health issues. The thing about the vaccine is that it can harm anybody, and it has harmed anybody, completely healthy people. And to me, that's much scarier. Are we aware of what the average age of people that are getting harmed by the vaccine? Is there any way of knowing that?
Yeah, I'll let this be the last question because I'm going to have to get on another call. But let me say that you're right. The natural infection, the respiratory infection, is amenable to risk stratification. We know people over 50 and then higher ages, higher risk. They need early treatment. We know that not everybody's going to get COVID. We know that less than 1% of people ever come in contact with COVID. But the vaccine's different. We know when we give the vaccine, 100% of people get it. Obviously, you get a shot in the arm, you've got it. You can't get it out of your body. And then once that happens, even though it's rare compared to the number of people who've gotten it, we do know that seniors, people in their 70s and 80s, are the ones dying of the vaccine. And we know that younger people are the ones developing the non-fatal syndromes, the heart, neurologic, hematologic, and immunologic. So the vaccine is very deterministic. Now, we wish half of Americans took the vaccine. We wish them well. People in my family took it. We wish them well. We don't wish anything bad on them. And the vast majority of people got the vaccine, and they made it through it, and they're fine now. Well, hopefully, there's something good that's come out of it. But it doesn't mean that we can ignore what's happened to basically 500,000 or more Americans. It didn't work out okay for them. And I think we should show compassion for this. We should show remediation. We should show mitigation. We should actually mitigate the risks for the next person coming. I think that's what this is all about. So I'll let that be the last word.
Yeah. One last thing. It's you see people say, "Oh, I know people who've gotten the vaccine and they're fine," and that's their example of the vaccine is safe. And I'm like, my kids eat peanut butter and jelly all the time and they're fine. That doesn't mean if somebody dies of peanut butter because they're allergic to it, that didn't exist, that didn't happen. So having an example of one person or two people being fine after getting the vaccine doesn't necessarily say for everybody,
Right. Safety has to be proven. You're right. Listen, I have to go. Thank you so much.
Take care. Thanks for your time.
Okay. Bye-bye.